Welcome to StudyNeuro. This presentation focuses on the clinical presentation of posterior communicating artery aneurysms, with emphasis on the symptoms, neurological signs, and important diagnostic clues that help identify these lesions early in clinical practice. Early recognition is extremely important. We will examine the common symptoms patients present with next to the neurological findings associated with aneurysm rupture and local compression, while also discussing the clinical significance of oculomotor nerve palsy and the key differences between hemorrhagic and ischemic presentations, because these patterns often guide urgent diagnosis and early management decisions in neurosurgical and emergency settings. Join the StudyNeuro community for high-yield neuroscience education and practical clinical insights shared across YouTube, Facebook, TikTok, Instagram, X, under the StudyNeuro platforms. More neuroscience content will be coming soon. Posterior communicating artery aneurysms are among the most frequently encountered intracranial aneurysms in neurosurgical practice, and they commonly arise near the subarachnoid segment of the internal carotid artery, where important neurovascular structures are closely related. Location matters significantly here. But clinical presentation varies from patient to patient because symptoms are influenced by aneurysm size, the direction in which the aneurysm projects, whether rupture has already occurred, and the degree of involvement of nearby nerves and vascular structures, all of which shape how the condition appears during neurological evaluation and emergency assessment. Early recognition improves outcomes considerably. Detecting these aneurysms before major neurological deterioration develops can reduce complications and support earlier intervention during a critical stage of disease progression. When a posterior communicating artery aneurysm ruptures, it leads to subarachnoidhemorrhage, where blood spreads into the subarachnoid space and causes a sudden rise in intracranial irritation and pressure. Patients typically present with a sudden, severe headache, often described as the worst headache of life, along with neck stiffness and repeated vomiting due to meningeal irritation. This presentation is dramatic. As the aneurysm exerts local mass effect, it begins to compress nearby cranial nerve structures, especially the oculomotor nerve, leading to eyelid drooping, double vision, and a dilated pupil on the affected side, which are classic signs of nerve dysfunction in this region. In more severe cases, the hemorrhage extends beyond the initial site and involves adjacent brain structures, including bleeding into the temporal lobe or spread into the ventricular system, both of which are associated with a more complicated clinical course and a higher risk of neurological deterioration during the acute phase. Patients with posterior communicating artery aneurysms commonly present with symptoms related to hemorrhage, cranial nerve compression, or raised intracranial pressure. Sudden, severe headache is a frequent complaint, often occurring with pain around the eye, double vision, drooping of the eyelid, vomiting, neck stiffness, or other visual disturbances, depending on aneurysm size and rupture status. These symptoms should never be ignored. When rupture leads to subarachnoidhemorrhage, the classic presentation is a sudden thunderclap headache that reaches peak intensity within seconds, followed by neck pain, nausea, vomiting, and sensitivity to light as blood irritates the meninges surrounding the brain during the acute hemorrhagic phase. Clinical examination may reveal neck rigidity and positive meningeal irritation signs, such as Koenig and Brudzinski signs, while more severe hemorrhage can produce reduced consciousness, agitation, confusion, or focal neurological deficits that suggest significant brain injury and worsening intracranial pathology. Oculomotor nerve palsy is one of the classic clinical findings associated with posterior communicating artery aneurysms because the aneurysm often lies close to the third cranial nerve and may compress it as it enlarges. Patients commonly develop double vision, drooping of the eyelid, and blurred vision due to impaired extraocular muscle function and parasympathetic fiber involvement. This finding is highly important clinically. On examination, Ptosis and pupillary dilation are common signs, and these abnormalities strongly suggest compression of the oculomotor nerve by an expanding aneurysm, particularly when symptoms appear suddenly or progress rapidly over a short period. When hemorrhage extends into the temporal lobe, patients may develop altered consciousness, seizures, confusion, or difficulty with speech, depending on the extent and location of brain involvement, while focal neurological deficits can occur if surrounding cortical structures become injured during the hemorrhagic process. Ischemic complications develop differently. These symptoms result from reduced cerebral blood flow and may present with weakness on one side of the body, sensory loss, visual field defects, or memory impairment when vulnerable brain regions receive inadequate perfusion after aneurysm rupture or vascular compromise after aneurysm rupture or vascular compromise. Raised intracranial pressure develops when bleeding, swelling, or impaired cerebrospinal fluid circulation increases pressure within the skull and begins to compress normal brain structures. Patients commonly present with severe headache, repeated vomiting, reduced consciousness, and progressive drowsiness as intracranial pressure continues to rise during the acute phase of illness. This can deteriorate very rapidly. Papilledema may also be seen on examination, reflecting increased intracranial pressure transmitted to the optic nerve, although it may not always be present early in the clinical course after hemorrhage or neurological decline. Certain symptoms should immediately raise concern for aneurysm rupture or worsening intracranial pathology. A sudden severe headache, acute third nerve palsy, rapid decline in consciousness, new focal neurological deficits, or seizures developing after headache onset are major warning signs that require urgent neurological assessment and immediate imaging evaluation. In summary, posterior communicating artery aneurysms often present with symptoms caused by hemorrhage or compression of nearby neural structures, and these findings frequently provide the earliest clues during neurological evaluation and emergency assessment. Certain symptoms are highly suggestive. A sudden severe headache, together with third nerve palsy, should strongly raise suspicion for a posterior communicating artery aneurysm, especially because the overall presentation is influenced by aneurysm size, rupture status, and the direction in which the aneurysm projects toward surrounding neurovascular structures within the suprasellar and parasellar regions. Early recognition and urgent treatment improve patient outcomes significantly. Prompt diagnosis reduces complications and allows earlier neurosurgical intervention before major neurological deterioration develops. Join the StudyNeuro community for focused neuroscience education and practical clinical insights shared across YouTube, Facebook, TikTok, Instagram, and X under the StudyNeuro platforms. Like, comment, share, and subscribe for more neuroscience content. Thanks for watching, and stay tuned for more.